Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and MedTalks, I welcome you all to yet another episode of Diabetes Essentials with Dr. Sanjay Kalra. Today's topic is very interesting topic: diabetes remission, facilitation through drugs. And today's session is brought to you by your zero calorie electrolyte drink, Inazal Zero. Now, before moving forward, I would like to announce last week quiz winners. Dr. Devraj Bhai Dolaria from Surat, Dr. Shantanu Kumar Bhattacharya from Kolkata, Dr. Bharat Parveen Mittakota from Surat, Dr. Ravi Bhatt from Sirsi, Dr. Sujit Kalsi from Noida, Dr. Anand Purande from Mumbai, Dr. Amrut Gundecha from Pune, Dr. Sarfaraj Arzu Sheikh from Mumbai, Dr. Ashutosh Das from Tamluk, Dr. Shashi Khare from Bhopal, Dr. Ashwini Kumar from Kanpur, Dr. Javed Ahmed from Lucknow, Dr. Satish Kumar Jain from Bangalore, Dr. Chandra Bhushan Prasad from Sitambari, and Dr. Rinku Gupta ji from Mumbai, and Dr. Sanjeev Puri from Hoshiarpur, and Dr. Sumita Sharma from New Delhi. So I would like to thank all the doctors to take part in the quiz. Now, to move forward, I would like to give the podium to our beloved Dr. Sanjay Kalra, Chairperson, Education Working Group, International Society of Endocrinology, and past President, South Asian Federation of Endocrine Societies, Bharti Hospital, Karnal. Over to you, sir.
Thank you, Ankur, and good evening, everybody. It's always a pleasure being part of FDC Diabetes Essentials. And in every episode, every Sunday night, we keep on discussing different aspects of diabetes care. We welcome everyone to the show and we acknowledge all the questions. Apologies to Dr. V.K. Goyal, sir, we got late today. And we acknowledge all the questions regarding remission, cure, reversal. Also, why is there a rise in diabetes cases in India? But today, let's speak about something very specific. And we'll talk about how to facilitate remission. Now, if we want to facilitate remission, first of all, we need to know the definition of remission, isn't it? And we need to know the difference between remission, reversal, and cure. So let's talk about that first. First of all, there are different types of diabetes. And here we are talking about type 2 diabetes. Type 2 diabetes is characterized by both insulin resistance and insulin secretory defect, that is insulin deficiency. Both of them are needed in order to cause type 2 diabetes. And since the pathophysiology is multifactorial, it is highly unlikely that there will be a cure for diabetes. Now talking of reversal, you can reverse hyperglycemia, but it is difficult to reverse the basic pathophysiology. So that will always remain. You can keep it under control, but it would be a very difficult kind of endeavor or a very long shot to say that we can abolish insulin resistance or we can bring the pancreas back to 100% normal in terms of insulin secretion. One reason for this is that by the time diabetes is diagnosed, the beta cells have already lost 50% of their ability to secrete insulin. So therefore, insulin reversal is also a bit difficult. But what is easily possible is diabetes remission. Remission means that we can take the patient into a phase where the person is able to maintain glucose levels within normal range with lifestyle modification alone. This is diabetes remission. But the full definition of diabetes remission also includes that this should be done without any abnormality. For example, if the person develops renal disease, hepatic disease, let us say the person goes on a starvation diet, then obviously glucose levels are going to come down, but that doesn't mean that the patient is healthy. The patient's glucose levels have come down because of liver disease or kidney disease or maybe hypothyroidism or hypopituitarism or because the patient is starving. So that is not what remission means. Remission means that the person is healthy and is able to maintain HbA1c targets within levels. Now, there is something known as the ABCD mnemonic. This was coined by Lee et al. And this was actually coined in a bariatric surgery perspective. So what they found out was that people of young age, adults of young age, and remember the denominator here is type 2 diabetes. It is not type 1 or LADA. So young adults with a high body weight or body mass index, adequate C-peptide or pancreatic reserve, and a short duration of diabetes, ABCD. These were people who were good candidates for remission of diabetes after bariatric surgery. This ABCD holds true for medical facilitation of remission as well. So, younger adults who have been recently diagnosed to have diabetes, who have an adequate C peptide reserve, and who have a high body weight and are willing to reduce it, these are the people where remission is possible. We added an E to this, and the E is energy and enthusiasm of the patient. If the patient is energetic, enthusiastic, is willing to do what it takes to lose body weight, then the chances of remission are high. But the patient cannot do it alone. We also need to help. So, if the level of engagement is high and you are able to educate the patient properly, then again, you will find that chances of remission are higher. So, this becomes our ABCDE mnemonic. We have published this in the past, but then we realized that it's not enough for the patient and us to be good friends and to engage with each other. You need the family as well. So, you need facilitatory family support. That should be optimal. So, if we all work together, the patient, the family, and us, we have a chance of creating remission in young men and women who have a short duration of diabetes, who are obese, and who have adequate C peptide reserve. This is ABCDEF. But then G is guided physio-friendly drug choice. So that's what our topic is for today. What are the drugs that we can choose? The physio-friendly drugs that we can choose in order to guide the patient towards possible remission. Whether you are aiming for remission or for control, either way, we should have a physio-friendly approach. Physio-friendly means that we should advise drugs with a physiological mechanism of action. Drugs which are insulin independent, which are beta cell sparing, which at the same time have a low risk of hypoglycemia and also offer pleiotropic benefits like weight loss, cardiovascular safety and protection, renovascular safety and protection. That's what being physio-friendly means. You are friendly towards the physiology of glucose dyshomeostasis. You are friendly towards the patient because you are causing less hypoglycemia and you are helping in weight loss and in safety and protection of all the viscera, including the heart and the kidney. So this is physio-friendly approach in terms of drug choice. At the same time, do not forget exercise and dietary modification. That is the basic cornerstone of all type 2 diabetes management. When we are choosing physio-friendly medication, choose metformin and try to choose any of GLP-1RA. We have oral drugs available as well, like semaglutide, injectables like liraglutide. So any of GLP-1RA, SGLT2 inhibitors, or alpha glucosidase inhibitors. All these are calorie restriction mimetics. So if we understand that diabetes is a state of carbohydrate intolerance, diabetes is a state of carbohydrate intolerance, it stands to reason that the treatment should be restriction of carbohydrates. We shouldn't stop carbohydrates totally, but we can restrict them in a physiological manner. Again, do remember that if you go below 100 grams of carbohydrates per day, your patient is at risk of ketosis, starvation ketosis. So please do not go below 100 grams of carbs per day in any situation. When you prescribe an SGLT2 inhibitor, you are working like a calorie restriction mimetic. We are not restricting calories. Calorie intake is not going down, but it works like a restriction mimetic because it takes out calories from the kidney. When we give an alpha glucosidase inhibitor like voglibose or icarbose, again, we are not restricting calories, but the drug is acting like a calorie restriction mimic at the level of the gut by reducing absorption or digestion and absorption of carbohydrates. GLP-1RA are calorie restriction mimics and they are also calorie restrictors because they directly reduce appetite. But these are physio-friendly, and since we understand the definition of diabetes, a state of carbohydrate intolerance, we now understand why we can use these carbohydrate restrictors, GLP-1RA, or carbohydrate restriction mimics, GLP-1RA, SGLT2 inhibitor, AGI, to start therapy. This is physio-friendly. If your patient is obese, you can always start obesity-reducing medications as indicated. Orlistat is one example which is approved in the country, and others can be used off-label if required. It is also important to understand the needs and preferences of the individual patient while prescribing pharmacotherapy. And we call this being psycho-friendly. So if the first concept of trying to achieve remission is physio-friendly approach, the second is psycho-friendly approach. Be friendly with the patient. Offer therapeutic patient education. Patient education itself has a therapeutic effect. Ensure that your patient gets the right information about diabetes. Use soft and salutogenic language. Salutogenic means health oriented, happiness oriented language. Focus on the advantages of good glucose control. Be optimistic. At the same time, be realistic as well. So, being optimistic while being realistic, this is an art that we all have to learn. So, see, so simple so far. Just be physio friendly, be psycho friendly. Share information about remission in a manner that is accurate, empathic, interactive, optimistic, and understanding. AEIOU, very easy to understand, reality, be realistic. Also stress upon the advantages of good glucose control, upon the ability of the patient to modify lifestyle and monitor himself or herself. Focus on the opportunities for health and the unique strengths of each individual. Be positive. You may wish to speak about the disadvantages of bad glucose control, about the lack of good lifestyle in a particular patient, about the opportunities for despair, for sadness, for sorrow. But these will not take you too far. So be positive while you're speaking with the patient. Don't focus too much upon the negative things. Let us say your patient comes to you with a 12-page report. Doctor Sahab, I got this complete health package done. What does it say? Now, inside of you, you may be irritated because most of the tests were unnecessary. But what you can say is, all your reports are perfect. See, your blood quality is very good. Your kidneys are fine. Even most of your cholesterol is fine. This is okay. That is okay. Now the HbA1c is high. That's an issue, but we can fix that. So focus less upon the negative thing, which is the HbA1c 12.7% here maybe, and focus more upon the positive things. Highlight that. So you might wish to say, thank you. You've taken such good care of yourself. That is why your kidneys are good and your liver is fairly okay. But we need to take better care so that we can bring the HbA1c down as well. So that even 2 years or 10 years from now, your kidney and heart are equally healthy. So that's the way to follow while counseling your patient. And this is a psycho-friendly approach. We need to be physio-friendly, psycho-friendly. And being psycho-friendly can be also termed as being person-friendly. So when you speak with the patient, talk about what is to be done, talk about the outcomes, and then explore potential facilitators and barriers towards these outcomes. How can we facilitate better health for you? If there's an issue, please contact us on WhatsApp. Or we are not able to answer on WhatsApp, why don't you come back and show us again after 15 days? What are the barriers? You cannot get an HbA1c done in your part of the country. Okay, that's fine. You do a glucose every 1 week and let us know. Initiate the appropriate lifestyle and medical management. Lifestyle, it's not safe for you to go out into the streets and exercise. It's too cold outside or the air is polluted. You cannot do outdoor exercise. Okay, why don't you climb stairs within the house up and down 10 times? So find the appropriate lifestyle management for a particular patient. Vascular risk reduction. We are giving you these 1 or 2 tablets. These are for glucose control. But see all the others, they are for prevention. This tablet is meant to help you prevent stroke. That tablet is there to help prevent heart attack, to give you a young heart, so that even when you are 70 or 80 years old, we are able to dance at your granddaughter's wedding. That's the way to promote vascular risk reduction. We want to dance together at your granddaughter's wedding. That's why we have to take these drugs. So, of course, now you won't use that for every patient, but the point is take a history, find out what the patient's needs are, and work towards a healthier, a happier, a more harmonious future. And work as we. We means together, the patient and us together. This is not a one-off affair. You have to monitor the patient regularly and titrate therapy as required. And undertake to being part of the team with the patient, even after remission, being part of the team along with the patient, even after maybe remission has occurred and pharmacological therapy has been stopped. So see again these AEIOU concept, agree upon what is to be done, explore facilitators and barriers, initiate the right treatment, observe regularly, and undertake to continue in the long term. The long term is important, but so is the short term. And let's look at the first 100 days or the first 1,000 days of diabetes. The same way that the first 1,000 years of a fetus and a baby are important for later neurocognitive function, the first 1,000 days of diabetes, especially the first 100 days, are the most important. We need to hit early, hit hard. We need to use physiological therapy, but we also need to be psycho friendly so that the patient sticks to therapy. So, physio friendly medication, discussing in a very psycho friendly manner or person friendly manner the concept of safe and positive glycemic legacy. These go a long way in improving long term health, and they actually end up extending longevity. So, longevity for you, for your patient, and for your practice and relationship. That's the importance of the first 100 or the first 1,000 days. So, we have been speaking today about how to facilitate remission. If you remember our ABCDE, let's come back to this slide. We talk about remission to young adults who are obese, who have adequate C peptide, and who have just developed diabetes, newly diagnosed. Talk about remission to people who are energetic and enthusiastic, who are willing to engage with you, who are willing to get educated. Encourage facilitation from the family and use physio friendly, psycho friendly therapy. Physio friendly therapy, metformin plus GLP-1RA, SGLT2 inhibitor, or AGIs. Obesity reduction if required through drugs or through surgery. Psycho friendly, we speak about this every week during FDC Essentials. The more we speak about it, the more I feel that we need to speak even more about it. And be practice friendly. Make this a part of your daily practice so that your patients understand the importance of teamwork and they understand the importance of the first 1,000 days in diabetes care. If we can do that, then very easily we can achieve diabetes remission in quite a few of our young patients. But let's look at our quiz questions for today. Now, tough questions this week. Which of the following drugs is not a physio-friendly medication? We mentioned three of them. Which of them is not mentioned? GLP-1RA, SGLT2 inhibitor, alpha glucosidase inhibitor, or insulin therapy? These are four questions. These are four options. So let's repeat question one again. Which of the following drugs is not mentioned as a physio-friendly medication for facilitating remission of type 2 diabetes? Is it A, GLP-1RA, B, sodium glucose cotransporter 2 inhibitors, C, alpha glucosidase inhibitors, and D, insulin therapy? Now let's go to our next question. Which approach is recommended for facilitating remission in type 2 diabetes patients? Which approach is recommended for facilitating remission in type 2 diabetes patients? Is it a pharmacotherapy approach focusing on insulin injections? B, implementing drugs that maintain metabolic homeostasis? C, strictly emphasizing the risk of complications to motivate patients? Remember, we spoke about this, strictly emphasizing the risk of complications to motivate patients. And D, avoiding patient education to prevent overwhelming the patient. I never thought of that. So let's look again. Which approach is recommended to facilitate remission? Which is psycho-friendly? A, pharmacotherapy using insulin. B, using drugs that maintain metabolic homeostasis. C, emphasizing the risk of complications. And D, avoiding patient education to prevent overwhelming the patient. Now, with this, let's come to our questions for today, our questions and answers. And I always look forward to this. Namaskar to everyone, especially Anup Shukla ji. Thank you. Uh, so the question was, 32 साल से शुगर बीपी है, क्या शुगर खत्म हो सकती है? So remission is possible in young adults with short duration of diabetes. If diabetes has been there for 32 years, chances of remission are minimal. And actually, if the insulin requirement goes down, our first diagnosis will be kidney disease, actually, or hypothyroidism. So we should not wish for that. Ninadji asked a question, is remission possible? The answer, yes. A, B, C, D, E, F, G will tell us in which patients it is possible. Good evening to Dr. Manu Sharma. And Sweet Candy says, why is there rise in diabetes That's because of we have become too lazy and we are eating too much of sweet candy these days. These are the two common reasons. We are genetically predisposed, but it is our lifestyle which is increasing the risk of diabetes now. Good evening to Dr. Vinay Desai as well and Dr. Devraj Duraria from Surat in Gujarat. And good evening to Dr. M.A. Lambe and Dr. Siddharth Dhanger from Mathura. So we just discussed remission, reversal, and cure. In English, they have different connotations. In Hindi and Gujarati, it is difficult to differentiate. But basically, cure or reversal means that you have managed to get rid of the disease forever and ever. Remission means that you have brought the glucose down, but you still have to be careful because it can come back anytime. And good evening to Dr. Gauri Shankar from Karnataka, who shares a case of a 45-year-old patient with TSH 14.5 and ultrasound showing diffuse thyroid swelling. So since there is no nodule in the ultrasound and it's a diffuse swelling, TSH is 14.5, the first line of therapy would be medical using L-thyroxine. We can get TSH done again after 6 weeks and 12 weeks. Usually with this, the swelling will subside. If the goiter is so large that it is causing obstruction of the esophagus or the airway, patient has difficulty in swallowing, patient has difficulty in breathing, only then will we think of surgery. Or if the patient has a thyroid nodule and the FNAC shows a malignancy, then we'll think of surgery. Otherwise, it should be medical management. As long as there are no obstructive symptoms, as long as there is no malignancy. With the TSH and ultrasound, again, surgery you will think of only if there are obstructive symptoms, obstruction of the airway, obstruction of the esophagus, or if there is a malignancy, or if the aesthetics is such that the patient says that this goiter impacts my professional or personal life. Maybe the patient is not able to get married, or the patient is not able to get a job because of the goiter. Then you will think of surgery, but that would be cosmetic reasons. Anticoagulant use in diabetes is a very often asked question. The indication for anticoagulants will never be diabetes. The indication will be atrial fibrillation, it will be valvular heart disease. These are the indications for anticoagulant use, not diabetes per se. Dr. Shantanu Shukla asks if vildagliptin is safe in NASH with type 2 diabetes. Yes, up till an SGOT-PT of 2 to 2.5 times normal, you can use the drug. But linagliptin would be a safer DPP-4 inhibitor for patients with hepatic impairment. Linagliptin will be the safest, and vildagliptin will actually come at the bottom of the choices in DPP-4 inhibitors. Cyclopyrox olamine in itching, yes, you can use if you wish. Hydroxyzine tablet would be a much cheaper alternative, but that is associated with sedative effect. It is anxiolytic as well. So cyclopyrox olamine you can use. This is for itching, and you have to find the reason for itching. Many a times itching will be because of dry skin, so a moisturizer will be required, or it can be a variant of neuropathy. So the same drugs that are used for neuropathic pain, they can be used. Letters not seen properly, Dr. Vinay. Apologies. Perhaps we can check. This FDC Essentials is available both on YouTube and on Facebook. So try the other one next time. Oh, okay. Again, from Dr. Lambe's screen is not visible. So apologies for that. And just try either of Facebook or YouTube next week. Thank you, Dr. Anshul Singh, for your kind words and for being with us. Dr. Anshul works in Chhattisgarh. In type 2 diabetes, when to start cardiac drugs? So statin would be the first drug that we would use. Statin is indicated. You can actually use in any patient with type 2 diabetes who is at high risk of cardiovascular disease. Some people prefer to start statins in every diabetic above the age of 40 years. Aspirin should be used only in patients with established ASCVD, not for primary prevention of ASCVD. And the other drugs like beta blockers, ACE inhibitors, ARBs, they should be used as per blood pressure if there is an indication. And you can also use ACE inhibitor ARB in patients with albuminuria to prevent progression of albuminuria. Good evening to Dr. Shashi Khare and Dr. Yogesh Shuklenchwar as well. Dr. M.A. Lambe also saying that slides bilkul bhi nahi dikh rahi. So we'll check on this. Apologies. And another question, TSH 12 on 100 micrograms suddenly went to 0.01. So it depends upon how long it took. But for the time being, you can reduce to 75 microgram. Don't go below that and check again at 6 weekly intervals. SGLT2 SGLT2 dose usually does not matter. We have fixed doses: 10 milligram for DAPA, 100 for Cana, and 10 or 25 for empagliflozin. Okay, so the question is on EMPA. I start with 10 milligram in everybody. The cardiovascular benefit will be same for 10 and 25. Increase to 25 only if glucose control is not achieved. So start with 10 in everyone. Bilirubin 4.5 in an adult with diabetes, insulin would be the only drug of choice for glucose control. Do not use any other drug apart from insulin until the hyperbilirubinemia has been taken care of. And thank you, Dr. Shantanu, for your kind words. So Ramzan series, we did not plan to do this year because we had done last year. We have had multiple episodes on Ramzan and diabetes at various platforms. Uh, Perhaps what we can do is we can take out the links of last year's series. We had 4 or 5 events and share with you again. So we'll just see. And Ankur is with us backstage today. If Ankur can reach out to you with the links to last year's Ramadan series. And SGLT2 inhibitor actually helps a lot, Dr. Mir Ramesh asks, because what happens? It helps in improving glucose control, and it also helps in improving cardiac and renal health. So it prevents long-term outcomes. Should we shift from 25 to 10 in Ramzan? No, no need for empagliflozin. We can use the same dose. Just shift from suhoor to iftar, from breakfast to iftar. So we can use the drug after iftar. Also, don't make the patient remain hungry for an extra 30 minutes. Let the patient break fast, and after the iftar meal, they can take their existing dose of 25 or 10 milligram empagliflozin, whatever is going on. So, and good evening to Mr. Kunal as well. So, today we have spoken about physio-friendly and psycho-friendly therapy. In physio-friendly therapy, we listed 4 drugs: metformin plus GLP-1RA or SGLT2 inhibitor or alpha glucosidase inhibitors. If you have a patient who meets your ABCDEF criteria, that is A for, let me see if I can present the slides again, and let's see if you can see it now. So let's see if we can get feedback from everyone. Yeah, now I wonder, I hope the slides are visible now. So let me show this slide. If you have a patient who is young, obese, has adequate C-peptide and a short duration of diabetes, is also energetic and enthusiastic, willing to get engaged, willing to get educated, also has facilitation from the family, then you should offer guided physio-friendly advice. Choose the right drugs, like we said. Choose the right drugs in a psycho-friendly, in a person-friendly manner. And then you should be able to ensure that the chances of remission are optimized. But do tell your patient that our aim is not just remission, our aim is good health. And good health is defined not only in the short term, but in long term as well. So if we are able to offer you the right medication, and if we are able to give you safe and positive glycemic feed legacy over the first 1,000 years of life, that is what is most important. That will help you improve your heart and kidney health and extend your longevity. So this is what is most important for practice in diabetes. With this, I'd like to thank everyone for their questions. I hope the slides were visible now. And one last question: how to do camps in a small village? So, do a camp only if you are going to give follow up. One off will not help. So, if you go, then the focus should be on teaching patients about diet, exercise, hygiene, also checking their blood pressure and glucose. But glucose, if you just do a random glucose, it won't help all that much. So basically, you can do the camp, but there should be a follow up also after the camp. So you should be able to ensure that follow up. Okay, the words were not visible even this time. So thank you, Dr. Lambe, for your feedback, and we will just look into it backstage and then get back to you. Thank you so much for the feedback. And we will try to share the slides with you later on. We will request Ankur to take charge of that. With this, I'd like to thank everyone for being with us today. And I welcome Kunal and Ankur who are with us backstage. Thank you so much.
Thank you so much, Kalra sir, for giving such engaging and informative talk. and your expertise and insights are very valuable for each one of us. And I would like to thank all the doctors to take part in our everyday Sunday sessions. Next week again, that we will be meeting with a new topic with new energy. Thank you so much for joining. Jai Hind.
Jai Hind.